everybody. I must appreciate Professor Sabda Malik, my worthy teacher, and Professor Farooq Sool for wonderful lectures, refreshing so many things, and must be very illuminating for you all here. I'm thankful to organizers, the chairman of organizing committee, the vice chairman, Shima Saab, the coordinators, the secretaries, Dr. Farida, for arranging yet another wonderful meet and for sharing the knowledge. You people are doing a lot, sir, for the propagation of knowledge. I must appreciate, and there should be a big hand for all of these. My topic today is CT brain indication and interpretation, primarily. Okay. I believe this is the first time in this conference the CT and MR is introduced. So I'm not lecturing, but my aim of the talk is to introduce you some basics of CT scan so that the foundation should be laid down for you people for upcoming lectures and for private practice, where you see the people do bring the films, do come up with the cases to have a look, and you should know by the end of this lecture when and how to refer a patient for the CT scan. Before going to the talk, the design of my talk is I'm going to talk about some of the basic principles, difference between CT and X-rays, normal neuroanatomy on CT, brain disease process evaluated with CT. There are two kinds of CT scans which are referred. One is without contrast, and other one is the with contrast. They both have different indications, different timing. Most of the non-contrast CT are advised in the acute settings. I'll just show you and talk to you and share with you. And there are certain indications with the post-contrast imaging. This is a CT scan machine. We can see on the one of the corner of this image, there is a gantry and the table. Patient is lie down on the table until it moves in out, and how the image is formed, I'll just show the slide. And of course, before doing the scan, we need to take the consent from the patient for these procedures. A basic principle of CT scan, we know that, we use X-rays in CT scan as we use in the normal X-ray routine. Images are required in a 360-degree rotation around the patient. Can you fix it, please? Ji? Next slide. Okay. This is how a patient is lie down in the X-ray machine. The view is as if you are standing on the head side of patient, and all around a ring is formed which has a detector in it, and the rotational tube which goes around 360 degrees, making the axial slices and through the region of interest. Like if we are talking about brain today, it is certain slices from the base of the skull up to the vertex. Images are taken, and slices may be taken from 0.6 mm to 10 mm for the brain imaging. A few words about the difference between what an X-ray is and what an CT scan is. In X-ray, we create 2D image, and they're used primarily for bones and its pathology. We can't see the soft tissue or the brain on X-ray, but on CT scan, it creates 3D image used primarily diagnostic condition in organs and soft tissues. As I told you, there is a 360-degree rotation of the X-ray tube which takes the image. But please mind you, one CT scan of brain is equal to 100 to 250 X-rays of skull. So that means a lot of radiation is given to the patient. So please, patient should qualify in your clinic for CT scan before you refer it to a CT scan. Otherwise, unnecessary CT scans give a lot of radiation to the patient, to their eyes, to the thyroid, and other important structures. The unit for the radiation is millisievert. One CT scan gives about 1.6 millisievert of radiation to one patient, which is comparable to natural background radiation of 7 months. So a lot of radiation is involved. So we have to evaluate the patient before referring it for a CT scan. A little bit of comparison. This is the normal X-ray skull. We see solid bones. We see the calcaneal, temporal bone, but we cannot see the soft tissues. But on the axial tomography, we're starting from the base up to the vertex. We see the details of brain. We see the sulci gyri. We see the ventricle, the CSF spaces, the fox inside. So we see the details of brain itself. This is a very important slide for you. How do image appears? CT findings are described as densities. What does density means? Density means the compactness of a tissue, which has certain atomic number. That means we, on a CT, describe a thing as a isoic dense, hypodense, or a hyperdense. So these are the three terms we use while writing a report or a reading. So what does mean hyperdense mean is, which is on higher side, that is hyperdense, is brighter in appearance. In brain, it can be blood, it can be bone, very bright. Whereas a hypodense, it is darker in appearance, and this is like fluid in CSF spaces or edema. I'll just show the example of that in coming slides. So remember the term isodense, hypodense, and hyperdense. A few words about what happens actually when patient is exposed to the X-rays. There is a term used, attenuation. We have read in our physics at FSC level, when radiation are thrown upon certain soft tissue structure, there is variable attenuation according to tissue density, and for that there is this grayscale mapping. This is a bar which map the absorption power of the tissue, and it is assigned certain number. The center part is water, which is on the scale is 0. And there is a plus side, there is a minus side. As we go, as with the grayscale, our tissue goes towards the plus side, it will be brighter, brighter, brighter in the end. So, whereas 0 is water, this would be black. As we move to the minus sides, the findings will be darker and darker. So, the bone on the plus side will be brighter on CT scan, soft tissue intermediate, water will be black, fat will in the minus side will be darker, and air will be further darker. So you should keep in mind what you are seeing, either it's brighter or hyperdense or a hypodense in appearance. Another aspect, when you see a film in your hand, how to look on the side, which one is the right side, which one is the left side. So remember, when you hold a film in your hand or monitor, the image side, which is on your left side, is the right side of the patient. You are viewing as if you are standing on the foot end of the patient. Patient का पाँव इधर है, सर उधर है, उधर से आप खड़े देख रहे हैं. So your left side, you think on the left side, the image on the left side is the right side of patient, and on your right side is the left side of the patient. This is the axial section, and this is the coronal section. This is how you look at the right side and the left side. There should be a clear concept about this. A few words about windowing levels. These are the certain parameters which has to be adjusted in the machine, and the computer adjusts it, because when the technician is doing whatever we are aiming at, either we are aiming at the stroke, or ischemia, or suspecting a bleed, we set the certain window level to see that in clarity. Like, if you see, do we see the hyperdense area in the brain? This is subarachnoid hemorrhage, and we set this CT scan on a brain window. When we set this on brain window, we clearly see the hyperdensities here in the brain. For viewing the soft tissues outside this skull, because there is a trauma, there is a bullet here, we set the window at the soft tissue level, and for the bone level, we have to set the window at the bone window level. So different windows are used for different structures while scanning. So what to see in a brain scan? When you come across a brain scan, what to see? Remember a mnemonic. Blood can be very bad. So in blood, B stands for blood, C stands for cistern, and again B stands for brain tissue, V stands for ventricles, and B stands for bone. So if you remember this sequence, you will have something in your mind to look at. The blood, we got to see blood, cistern, brain tissue, ventricles, and bones. What are our diagnostic goals or indication for a CT scan of the brain? We look for brain skull injuries, bleed in the brain, bone traumas, and certainly the blood, the bleeding aspects again, and the tumors, infections, the malformations, structural abnormalities, and the checking the effectiveness of medical treatment in shrinking brain tumors. Before going through the images and pathologies, we must have clear-cut idea about anatomy of the brain. I'll just show you a few images. This is one of the axial image of the brain. We see the gray matter and the white matter. Gray matter is slightly grayish in appearance on a CT scan, whereas this white matter is slightly low and on the darker side. I told you whatever the darker is towards the minus side. Either it's a fat or air. We don't see air, but this is the axon here has a lot of fat in the white matter. That's why it's appear blackish. This further black is CSF, and these are CSF spaces. These are all black. As I told you, the density, hospital density for fluid is 0, and for CSF is around 10. This is normal anatomical landmarks. We see the choroid nucleus, lentiform nucleus, thalamus, cortex, and the whitish, the hyperdense. So this is hyperdense, is bone, and this hypodense is fluid or CSF. Another slice at further upper level, we see the frontal lobe, temporal lobe, and occipital lobe, and of course the bone. One more slice further up, lateral ventricles, sulci gyri, gray matter up here, and white matter. This is a CT example of CT angiogram with contrast. This is circle of Willis, the main arteries of the brain and their branches with contrast highlights the vessels. Another example of CT angiogram of neck. So my main focus is on neurological manifestation because these are the emergencies. This we do in the acute settings. What we do, if we come across a patient who has sudden neurological deficit, so when you evaluate clinically, you come to conclusion that this guy or female is having probably the stroke. Stroke can be ischemic or hemorrhagic stroke. I'll just show you the slide but before going to talk about stroke, we should know there is a very important term is brain edema. So why it's important, I'll show in coming slides, but we should know there are different type of brain edemas we come across on a CT scan or MR. The one is cytotoxic edema, This is due to the ischemic insult, which comes in minutes to hours. The other one is vasogenic edema, and this comes in the later stages, is commonly associated with neoplasm or infections, and the interstitial edema and combined edema in the brain tissue. We'll have a look. How do they look like? What is cytotoxic edema? It is increment in the total brain water produced when the excess water swells the cells rather than expanding extracellular space. When there is ischemic insult, what is ischemic insult to the brain? The artery supplying to the brain is blocked by either thrombus or embolus, and suddenly blood supply to the cell is halted. Once the blood supply is halted, the sodium and potassium pumps are not working properly of the cells. There is influx of chloride influx, and this lead to retention of fluid. जो हम CT scan में ischemia या infarct देखते हैं, this is the reason we see that swelling of the cell which appear hypodense. Stroke, this cytotoxic edema comes in minutes or hours. This is one of the example. This is normal brain. We see the hypodense lateral ventricle, the normal brain, Sulci-Gare pattern, and hyperdense bone. But over here you see a diffuse hyperdensity on the left side of the brain. This is cytotoxic edema due to ischemic insult. This is not only edema, but it's also giving a lot of pressure on the ipsilateral ventricle, and there is a midline shift. This is of significance. On the other hand, vasogenic edema, this is extracellular fluid accumulation due to disruption of blood-brain barrier and extravasation of serum proteins in extracellular spaces. Cytotoxics was within the cells, they swell up, whereas the vasogenic is extracellular due to breakage of blood-brain barrier, and this is seen mostly in the brain tumors, abscesses, shunts, thrombosis, cerebral hemorrhages. So this is one of the example of the vasogenic edema. It has very peculiar appearance. This is frog-like, finger-like appearance. You see fingers. If we go back, the cytotoxic was more diffuse, but this one is finger-like appearance. So when we come across a finger-like appearance, hypodensity, bell should ring in your head. This is not ischemic insult. Probably this is something tumorous pathology is going underlying, or some infective pathology is going on. This is comparison. Again, this is cytotoxic edema in the area of watershed area, and this is again frog-like, finger-like projections in this area, in the left temporal lobe. The third type of interstitial edema is seen in the hydrocephalic. It caps around the anterior horn of the lateral ventricles. So, moving further, CT head in acute setting, that's the key. Time is brain. We got to save the brain tissue, because once the stroke happens, मेरी फिर स्लाइड नहीं ठीक चल रही Okay. Once clinically you diagnose there is a neurological deficit, stroke is on, you got to rule out either it's an ischemic insult or a hemorrhagic. So you request for a CT scan. If there is hemorrhage, you cannot thrombolize the patient. That is the key for the CT scan. Once you come to know on a CT scan, it's not hemorrhage, it's simple stroke, it's gone. Up here. So the main aim of CT scan in neurological deficit is to rule out intracranial hemorrhage. That is very, very important. Once you know there is no hemorrhage, there are features of ischemia, you thrombolize the patient because ischemia comes through embolus or thrombus. So once there is hemorrhage, the plan of treatment is changed. We got to rule out other pathologies like tumors. We got to see the raised intracranial pressure and hernias. As I told you, what is a stroke? Stroke is clinical terms, sudden focal neurological deficit. Stroke are classified in two majors. I told you hemorrhagic or ischemic. Hemorrhagic stroke accounts for 16%, 16 to 20% patient present with hemorrhagic stroke. Other ischemic are, as I told you, blocked vessel by thrombus or embolus. I just talked about the cause of ischemic stroke, and this is very important. What appears on a CT scan within hours when we suspect a stroke? There is a loss of gray-white matter differentiation. This may see within 1 hour, in the 75% up to 3 hours. But in some cases, it's not necessarily you see any change in first 24 hours on a CT scan, whereas MR can show the changes on a CT scan within first 24 hours. Cortical hypodensity associated with swelling of sulci gyri. I told you about the cytotoxic edema, and there is a hyperdense vessel sign within 90 minutes. This is important. I'll just show what is a hyperdense sign in middle cerebral artery. Very early, patient presented with early neurological deficit. If you see carefully, we see differentiation of sulci and gyri on this side, but this side there is effacement as compared to this. These ridges are missing here. This is a very early sign of an ischemic stroke. So you don't see hemorrhage here. You have ruled out possibility of hemorrhage on the basis of clinical assessment. You ask for CT. This is stroke. Is evaluated. There would be evolution of this in further hours. By the end of one day, it's very clear. This is day 0, and up here, this is normal side. You see normal sulci and gyri pattern, and this is hypodensity due to cytotoxic edema. The stroke has evolved. So confirming that it's not bleed, it's an ischemic stroke. This is not a hemorrhagic stroke. Subacute, again, within 1 to 3 days, patient may bleed in the ischemic stroke. This is one, you see the oblong hyperdensity inside a infarct. This is hyperdense vessel sign. This is seen within 90 minutes onwards when there is ischemic stroke, because this area is of the middle cerebral artery, the narrowed one, and when there is acute thrombus, it shines through. It is hyperdense, and along with this, there is a large area of hyperdensity suggesting the ischemic insult in the territory of middle cerebral artery, and this is seen within 2 to 3 hours. One of the example of chronic stroke, you see the insulted area has liquefied further. This is normal ventricle, anterior horn, but on this side you see the dilated ventricle of this side because the parenchyma has lost its substance due to chronic stroke. Hemorrhagic stroke, I talked about 16% of cases there is a hemorrhagic stroke. This is one of the example in the cerebellum, and as I told you, hemorrhage appears bright, hyperdense because of the fact of the proteins of heme component of blood. They are much brighter as compared to ischemic stroke. A very common area of hemorrhage is in hypertensive patient. We come across this is the hypertensive bleed. This is paraventricular area on the left side, and there is slight edema in the surrounding areas. This is bleeding. You see whirly appearance. This is actually the AV malformation and the bleed, and there is some of blackish or darkish area which signify calcium there. A few words about hematoma and bleeds. In an emergency settings, there are certain hematomas we come across in emergency settings, epidural hemorrhage, subdural, and subarachnoid intraparenchymal hemorrhage. And the trauma causes about 45% of these type of bleeds. When we see the extradural hemorrhage, it is due to the rupture of the medial meningeal artery, and when we see the subdural hemorrhage, this is due to the veins leaking in the subdural space. Just touching the herniation is very important. When the brain has a pressure due to bleed, either is subdural or extradural, brain substance move to one compartment to other depending on the volume. And this is very important to assess the volume so that the surgical intervention must be there to save the brain, because if the herniation is in the cingulate gyrus, move from this in subfalcine area. This is the area where anterior cerebral artery lies. If it is under pressure, it will bring the infarction of the spline area. So it's very important to understand. This is a subdural hematoma, acute hematoma, causing compression on the midline and the ipsilateral ventricle. These are two examples of subdural hematoma and epidural hematoma. The subdural hematoma is along the convexity of the brain. It is crescent in shape. This is due to the bridging vein, and this is the convex lens shape epidural hematoma, which is biconvex in appearance. Again, example, this is the acute, is hyperdense, subacute is intermediate, and the chronic subdural hematoma is little hyperdense. Biconvex, I just told you, this is epidural hematoma, and you may see in some patients the both type of injuries like extradural and subdural hematomas. This is very important. You see hyperdensities within the cisterns of brain. These are diffuse hyperdensities, and the cause is here. This is aneurysm. This has ruptured, and the leakage of blood in the basal cisterns of the brain. Fractures. This is normal brain skull on a bone window. You see smooth, no stepping, no fracture, but up here is a step. This is a fracture along with soft tissue thickenings, quite obvious soft tissue thickening, and there is a fracture here. This is a post-traumatic fracture, which you see on a CT brain. We come across axonal injuries in trauma. This is deceleration and acceleration injury. In the thalami, we see foci of acute bleed, and sometimes contusion in the frontal lobe. You see foci of hyperintensities and hypointensities, and sometimes axonal injury, and this may lead to bleed in the ventricle. This is the right side ventricle, clean, hypodense, but they also bleed in the left ventricle. Intracranial tumors, a few words. We have a large number of tumors which are seen in the brain. Among the most common are the metastases. Tumor can be intraaxial or extraaxial. Intraaxial means in the substance of the brain tissue. Extra means outside the substance. This is one example. Without contrast, we see an area of hyperdensity and hypodensity in the front right frontal lobe and the front-like edema. When we give the contrast to it, it shines. And there is a midline shift crossing the midline, and there is subfalcine herniation also. This is GBM glioblastoma multiformis. Similarly, extraaxial tumor, very common meningiomas, they take homogeneous uptake. This is parafox meningioma. Again, example of a midline crossing tumor is glioblastoma multiformis, takes up the contrast and shines. About 40 to 50% brain tumors are the brain metastasis. When you see number of masses in the brain and the disproportionate edema around them, suspect the metastasis, and the history is very important, and previous record is very important. You see number of nodules in the brain, and these are the metastatic. Infections, the common infection is meningitis. If we don't do CT scan for simple infection to detect. You might not see anything when you are clinically suspecting meningitis on CT scan, but the scan is done to see the complications of infection. The complications are, they can be hydrocephalus, ventriculitis, abscess, spasm, and thrombosis. This is normal lateral ventricle configuration, but due to outflow obstruction due to infection, the ventricles are dilated, and this is a case of ventriculitis enhancing of. Can I have 2 minutes, sir? Oh, thank you very much. This is an example of brain abscesses, the ring enhancing, and again I showed you the frond-like edema. You see the frond-like edema enhancing lesion in the right side of the cerebellum, pushing the midline structure and the fox to the opposite side. And common in our settings are the tuberculomas, multiple ring enhancing lesions, edema, and when you give contrast, we have number of ring enhancing lesions. So these were the few features we should know as a baseline CT scan. A little quiz for my dear audience sitting there. Can anybody tell what is this? Is it hypodense or hyperdense? Please speak. Hypodense. So what it could be is a diffuse ischemic insult. Excellent. Next, frond-like. Is it cytotoxic edema or vasogenic? Vasogenic, excellent. And this one? This is a bleed. Bleed is hyperdense. And what you see in this? Hyperdense vessel sign. Thrombus in the middle cerebral artery, I just showed you. And what are these? Epidural and subdural. Are these acute or chronic? Acute, because they are hyperdense. How about this? Fracture. Excellent. My job is done. And this is how cranial CT has assumed a critical role in practice. It allows, in acute setting, exclusion of hemorrhage. That is the most important thing. When the patient is suspected with a stroke, we have to rule out whether it's a ischemic stroke or a hemorrhage. For ischemic, we have to thrombolize. Thank you very much. This is for you, sir, Professor Farooq Rasool. This slide is for you.